Thank you for hitting play, and welcome to the series we're calling Data Pioneers. We're bringing together the brightest minds in the healthcare industry, supporting the transition to value-based care. We'll be highlighting the best practices, tools, lessons, and advice with a focus on data and analytics. I'm your host, Rich Waller from WellStack, and we're very excited to have you join us today. Welcome to Data Pioneers. We are super excited today to have Dr. James Bleicher as well as Michele Chulick on the show. Dr. Bleicher, Michele, really great to have you today.
Thanks for having us, Rich.
Thank you.
Awesome. So before we jump into questions, just kind of by way of background, why don't you each of you give us a quick high-level intro, a little bit about your background in the healthcare industry, just as we kind of get started here.
I'll go first. For the last 20 years, I've held numerous positions in the C-suite. First being the Chief Operating Officer for the Health Division of a major academic medical center. Next, I had a Chief Administrative Officer position and President of a Ventures group where I was responsible for population health, telehealth, and IT. And my last and most recent position was as the Chief Executive Officer for the largest health system in Wyoming, which is where actually Dr. Bleicher and I worked together, and he was the Chief Medical Officer. In all of those positions, I've had IT reporting to me. And in all of those positions, I've absolutely loved the use of data.
Excellent. Dr. Bleicher, quick intro.
Yeah, so I'm board certified in internal medicine, practiced medicine for many years before I got into administration. And like Michele, many positions in the C-suite, CEO, COO, CMO, and rural areas, urban areas, regional, local, all kinds of different things. Always interested in data and numbers. I was a math, computer science major back in the day, so have always been near and dear to me. And actually the last couple of years I've been practicing medicine again. So full circle.
That's amazing. I didn't actually realize that we were both math, computer science majors at one point. That's amazing. Well, great. So thanks again. And as we get started, I mean, our focus here is talking about data's role in the healthcare industry's transition to value-based care. So for each of you, what would you say has been most surprising on your journey in the healthcare industry in this area? Maybe Michele, we can start with you.
Sure. I think the most surprising is that healthcare is so data rich, but actually we fail to use the data effectively. I think we're often in a situation where we collect all of this, and now that we have electronic health records and we have some very sophisticated claims processing capabilities, and we are integrated, that data just keeps building, but we really are having a hard time using that data for effective analytics. And I think when you take a look at it, the data is one thing, but the analytics and analyzing that data in a very sophisticated manner is pretty much the window to some of the answers that we have as we move forward into value-based care. We've used data a lot for quality over the years, but it's been sort of static. It hasn't really been dynamic. And I think we're in a situation today within healthcare where we need to be much more dynamic in our use of data and our ability to analyze it.
Yeah, great answer, Michele. I would echo that it is a data-rich environment. And I think going back what Rich and I were saying with being math majors and understanding ASCII and the whole Unicode that they've come up with, and everything's supposed to be talking to each other. Back in the 90s, we said, every computer will be able to talk to each other. And now it's, you all have to be on Epic or Cerner or something to be able to get it to talk. I think the most surprising thing for me is how difficult it is to capture data and how dynamic it is in healthcare and changing in so many different aspects. And actually, I was thinking about this today, car manufacturing and how good they are with data, and they give warranties for 1 to 3 years on their cars. But after that, the data inputs that you don't have is how hard are people driving the car? Are they doing the maintenance appropriately? Things that are outside their control. And so they don't care as much about that data or worry about it. But in healthcare, there's where the issue is, because self-reported data is terrible. When they do observational studies and people say, are you following this diet? Are you doing this exercise? Or how are you sleeping? That data is not very good, because we're not very good at remembering what we're doing. And then we tend to tell lies, etc., to try to make ourselves look better or different. So when you put that into data, and now you're trying to do value-based care where those things matter as much as what you've done in the hospital, it really makes it difficult.
Yeah.
Yeah, absolutely. Please go ahead, Michele.
No, I'd agree with that, JJ. And I think it gets down to the element of trusted data, right? And we've talked about this in many different ways, but you can't trust something that comes, I hate to say it, from the patient, because to your point, you don't know how accurate it is. But then you get to data that you want to bring into your system. And there again is a trust factor. How was that data collected? Is your definition of a patient or a visit the same as my definition of a patient or a visit? And it makes it difficult. You'd think we would have figured this out by now, right? I mean, right, we've had electronic health records for over 20 years. And we've been able to build up that repository of data. You would have thought by now we would have been able to solve some of the issues that we have.
Absolutely.
Yeah,
oh, please, yeah.
Well, I was just going to say, doctors have memories like elephants, they say, right? So when
which is the problem.
Right, because we got this data. We started having computers in the 90s, and we started collecting billing data and other things. And then we're like, ooh, let's roll a bunch of this out. And a lot of it wasn't even close to accurate. And so in the back of their mind, physicians are still thinking, how do I know? And to Michele's point, where's this coming from? Who reported it? Is it the same widget as the way I look at a widget? And I don't think we've actually answered that yet. And a lot of places do measure things differently and time them differently. And Michele, you remember all the work we did with anesthesia in Wyoming, and what data we thought we had and what data they thought they had. And then we had to talk to them and adjust the way we were measuring things, because that's the way they interpreted it. And we wanted them to be able to react to what we were doing. And it, added a lot of length to the project.
Yeah, I thought about that as I was thinking about, how we've really used the data recently. And Rich, to the point that JJ was just making, this was a new contract for a private physician group working within the hospital. And we had a value-based care incentive as part of the contract. And it took us maybe months of negotiating.
Yes.
On what the definitions were that we were going to measure, where we were going to measure it from, where the data was going to be pulled from. I mean, but we finally got to a place where we all agreed. And so when, the first 6 months or the first year of the contract rolled around, we honestly didn't have to argue about the data, because we had already done that work up front.
Yep.
But I don't think a lot of people think about that today. And even if you can think about it, there are some payers that aren't ready to do that they don't have those definitions, that they don't collect the data in the same manner that other health systems do. And again, I found that out in working in rural America, that, some of the payers are not at all prepared to be able to go at risk with you. Even though you want to do that, they aren't capable of it. And part of it is their systems don't necessarily collect the data that is important for risk contracting.
And and let's double click on that a little bit in terms of, those, that are listening, that maybe are going through a similar challenge, or what did you learn through that process, or any best practices or tools that you could recommend, to others that are kind of either in the same situation or thinking about moving, that way, to, start negotiating more risk-based contracts, with their health plan partners?
Well, keep it simple, stupid, right? The KISS program. But I think that I think what happens often is systems start making plays with insurance companies, and looking at things before they brought the physicians in. So they kind of bring something that's half or three quarters baked already. And that was kind of the thing with anesthesia. We said, well, here's what we want to measure. And then they said, oh, wait a minute. And so we started over, but we didn't say this is what we're going to do and what it looks like. We totally work with them. And I know that's daunting, especially when you're talking about a value-based contract. And I remember was in St. Louis, and we had 8 hospitals, and we were working on value-based care. And we had a large Medicare ACO and a large primary care group, and we started working towards that end. And within 6 to 9 months at the operational meetings of the system, they told us that we needed to slow down. We needed to back off because it was affecting the bottom line because we were reducing too many surgeries, reducing tasks, et cetera. So, you got to get everybody on the same page. And it probably starts from both ends, working with the physicians, but working with your board at the same time, saying this is what we're going to do and why we're going to do it. And there may be some bumps in the road, but we need to get there, because the minute you show fear, things are starting all over again, and you're going to be in big trouble.
Yeah, certainly a delicate balance there for sure.
But I think to JJ's point, I think physicians and care providers, even a physician assistant who's working within a practice or a PCP practice, you need to involve them when you're going to begin to take risk. Because if you don't, they're not attuned to what you're focused on. They're not attuned to what the incentive opportunity is. And if, in many cases, if they don't change their practice, or they have everyone in that practice aligned, you're going to get such variation that you won't achieve the incentives or the value that you are hoping to create. So you can sit there all you want, from the C-suite or the CFO or the COO or whomever. Even the IT person needs to be involved, because what you agree upon with that payer or that particular group who you might be contracting with, you have to know whether the data can be collected. What is the source of the data? Do we understand the definition of the data? What will be the process? Do we have to normalize the data? I mean, some of that involves a lot of the IT people, your physicians, your CFO. So it's a whole group that needs to be involved along with the physicians in order to really agree on what the best metrics are when you enter into a value-based contract.
Yeah, and so this is a good segue. One of the things we want to touch on is sort of the role and day-to-day experiences of the clinical leaders, hospitalists, physicians within the health system during this transition. And it'd be great to kind of shed some light on some of those challenges, and again, kind of what is that day-to-day experience, and maybe some of those solutions. So maybe Dr. Bleicher, we could start with you on that. It'd be great to kind of understand your thoughts there.
Well, you'd like to say everybody's on the same team or on the same bus, but primary care generally is all over this, because that's what they're supposed to be doing, is managing patients on a longer term basis. So when you start talking to them, and a lot of the measures that we have for them are vaccines, colonoscopies, all the health maintenance type things that they're already kind of keeping track of. So they want to be incentivized. Like, if we're able to keep people out of the ED, I extend my hours, or not send them to the ED and do things. They want to be paid for that. When you are dealing with specialists who are often based fees on procedures, it's a little bit tricky on how you get everybody on the same page, because if you're truly doing it, you want to do less of the other things, or at least more appropriate levels of things. And how you pay physicians, because that's going to be one of their biggest things. Of course, they all say they want to do the right thing, right? There's nobody that says value-based care makes no sense. Of course, we want to have great service. We want to have great quality. We want to have great outcomes. Nobody will argue with that. But the way the system has been set up, although they tried to change it in the 80s with the way the RVU, RBRVF system didn't work, and specialists kept making more and more. That's the way the system's built. The more they do, the more they get paid. So when you're starting to talk about changing that, that's a whole conversation that I always started up front, trying to figure out the best way. Now, if you have, just for easy purposes, 100 patients, and you're only going to be dealing with a value based of 5% of those or 5 of them, it's not going to affect a big piece of their income or what they're working on. But if it's a much larger portion of what they're working on, then now you're talking about changing the way you pay them. And almost every system I know now, they pay by RVUs. There might be base salaries, but everything is RVU based, which is based on productivity, and you get a ton of RVUs for doing procedures. But procedures cost the most money. So in a value-based system, again, everybody wants to do the appropriate amount, but most people, not everybody, many people would agree that we're probably doing too much of many different things, back surgeries, et cetera. I won't name a bunch of them, but there are more efficient ways to do things. And I think that that's a big stumbling block moving forward, is how that you incentivize physicians to get the same outcome, but yet still compensate them fairly.
And yeah, please go ahead, Michele.
I think one of the issues, and JJ is spot on, but I think one of the issues that we have, and we've had for a very, very long time, is how do we get the right information down to the physician level? Right? How do we provide the ongoing metrics, whether it's on a daily basis, whether it's on a weekly basis, or whether it's by patient? How do we get that information to the clinicians who are making the decisions on the care and utilization for patients? And there are some systems, and I had one in Dallas where you had a daily dashboard come up, and it would tell us about the number of visits in the emergency room, tell us the number of patients that left without being seen, the number of surgeries the previous day. We were even at the point where we could look at revenue as it came in on a daily basis. But that was a dashboard, an operational dashboard that a lot of places don't even have today, which to me is essential as you look at keeping track of your bottom line and utilization. But think about the opportunity if we could get the clinicians, to your point, all of that information, that they agreed with all the RVUs. How many times do we have to argue about the RVUs with physicians, right? If you could get that information somehow about utilization on a daily basis with patient care in the acute care setting. And I just don't think that happens as much as it should be.
Yeah, I totally agree. The problem I see is, how do you, back to our data fidelity, how do you measure that? What does that look like? Because for a population, looking at how many casts, how many back surgeries percentage compared to others, you can do. But on an individual basis, you come to me as a specialist and say, you've done more casts than other people, or you've done more of these. And then they'll say, but my patients are different. And how do you know what this looks like? And that's why AI is also going to continue to have trouble in this realm, because they can't look at exactly what happened to the patient on that day. And to Michele's point, you have to have the operational data. We're working on the quality data, which many of us would argue whether what we're measuring is what we should be measuring in the first place. But I used to always say, because we have all these measures in the outpatient side, like I said, pneumovaxes, appropriate treatment of pneumonia, appropriate treatment of UTIs. But that's on the premise that the diagnosis was correct in the first place. So pneumonia can look like CHF. And so somebody may come in and they actually have CHF. And I think, oh, they've got a pneumonia. So I put them on the appropriate antibiotic for 3 days. So I get a check mark. Oop, you treated that correctly. But actually, it was a mild case of CHF. And so the patient, of course, thinks they got better because you gave them an antibiotic and they're feeling a little better. But now a month or so later, they're getting short of breath and have a cough again. And then say they end up in an emergency room and get an echo, admitted, and it's congestive heart failure. I've not seen any system, claims-based system, or any system that can go back and then say, oh, that patient, maybe they really didn't have pneumonia. You missed the CHF. And it's not a gotcha, you missed it, but it's, if you're going to be looking at quality and outcomes data and value-based data, how do you put that together so that everybody is feeling good about the fidelity of the data?
Right.
Right. And, so I think so much of value-based care, relies on solid, kind of team-based care or collaborative interactions. And, when you think about all the technology that has come, into the market over the last decade, or if we go back maybe 10, 20 years, how has collaboration improved, or has it, right? With all the technology in the market?
So, I think, so I'm currently working in a system that basically uses Epic. The hospital I'm on is not on Epic. So the fact that I can access the Epic on my smartphone and see what happened to that patient in other places and what they were thinking, I can read the notes, I can see the labs. So long as they're on Epic, it's all in there. And that's very helpful. So that's collaborative.
Yes.
If you're looking for it, you're out there looking for it. But comparing to when I practiced medicine 20, 25 years ago, when there was no such thing as hospitalist, physicians congregated at the hospital, right? You would see them in the halls, you would see them, in the doctor's lounge, and you always would talk, oh, hey, Joe, this case, remember? And you would talk about it. The way we have separated medicine out, and now we've added APPs, et cetera, I can consult a specialist and I may never see them. The APP or whatever will come down and maybe call the specialist, and then the specialist might come down at 7 a.m. or sometime when I'm not there, but it's very disjointed. We assume, and patients ask all the time, will my physician see all this data? Well, of course, they'll go on the computer, they'll see it, it's all there, and it is reported quicker. If the X-ray result, if I'm seeing it, it's on my chart everywhere, their physician, it's all there. But actual coordination and talking, no. They send patients, primary care almost exclusively sends patients to the ED if they're sick. That's how the system works now. They don't have time for them. They send them. Rarely is there a call. They just come in. And as a discharging hospitalist, I almost never call a physician. I put the discharge summary is real time. It's done that day, where in the past, 20 years ago, it might be a week later by the time they typed it. So again, data is real time, but that person has to look for it and has to find it. So it's better, but it's worse. It depends on how you look at it.
So I think I'm going to take maybe a little different perspective when, we look at how we've so improved the technology and so improved the capability. Yes, it's improved collaboration. It's also increased the speed to care or the speed to treat. But it's also created a lot of silos, believe it or not, in my thought process, right? If you're not on, to your point, JJ, if you're not on the same system, or if you go see a specialist that's not part of that system and that specialist can't access the information on your chart, all of the effort that we've gone through to reduce the cost of care and not duplicate testing has gone out the window. And our whole focus, in order to have this chain of information, was to be able to share all of the data, reduce the amount of testing, get everybody on the same page, reduce utilization of very expensive procedures or tests. But that's only true if you can connect it all together. And that's pretty tough if you're not one of the large faceted multi-hospital systems and you are in, Utah or Idaho or Montana or Wyoming or some of the Mountain West states where rural healthcare really is different than what you see in an urban setting or states that have very sophisticated health systems. So,
yeah, and you kind of discussed some of the challenges there on healthcare executives and administrators receiving leading indicators and analytics in a right time frequency. Um, how do you think about ROI, right? Like, let's assume we do achieve that. What's the return on investment for a health system to have, those leading indicators, on a daily basis, driving the organization? How do you think about the real return on investment of those type of analytics?
I think operationally, because right, you're talking about different analytics, quality analytics, utilization analytics, operational analytics. So I'll let Dr. Bleicher talk about the clinical analytics. But for me, the operational analytics are essential to be able to change processes and reduce cost. Some of those operational analytics are also essential to increase revenue. So you're tracking left without being seen. I don't want anybody walking out of my emergency room, right? I really want to make sure that I capture every single patient that I can to walk through that door. So they're essential for either reduction of cost and expense, decreasing utilization and cost, and increasing revenue. But you have to be able to have them on real time. You can't have them 15 days later, because everything that's occurred in that 15-day period, that's gone. You can say, oh, I'm going to change that process for the next 15 days, but it's going to take you 15 days to get it. So now you've lost the month. So it's got to be real time. It's got to be something that is manageable, approachable, and actionable for me from an operational perspective. And I think there are some systems that are there, and you can talk about it and you can bring it up in, C-suite meetings. But again, has to be actionable, has to be real time, and has to be trusted data.
Yeah, totally agree. And the Hawthorne effect works on quality data, also works on operational data. When people know you're measuring it, they're paying attention. And
It's true.
It's amazing because we all live by anecdote. Oh, I do this, I do that. I'm never late for this, that. And like with the anesthesia contract, you start measuring things, how long it takes them to get into the room or whatever. And most of the time it's kind of, you don't want to hit them with a cudgel, but most of the time it's, oh, okay, I didn't know that. And then boom, you get some improvement on that. And to Michelle's point, it's like, if you don't have that, it's flying blind. That's like flying in fog and not having any of your instruments. I don't know how people do it, and they probably don't do it very well. The quality data that we're using in a hospital that would be real time, but it's closer to operational than to quality, I would say, than real quality. And it's kind of the same thing. It's got to be real time when you're doing things. And, when you're looking at door to balloon times and, door to TPA times and different things with strokes and MIs, that makes sense, and when they get an EKG from the field, and it speeds things up, which we know the sooner you can treat a patient with one of those things, you've improved it. But it's really operational data. We call it quality, but it's operational data.
Good point.
Yeah, and historically, some of the things that I've seen, on kind of my journey is there's, the last decade or so, we've focused a lot with analytics on understanding, kind of the administrative process around, revenue cycle and understanding sort of how, the payer provider relationship is working, right? And so understanding how denials are happening, how do we improve process, how do we improve documentation? And as we move to, the value-based, side of this transition, and we're dealing a lot with the contractual and relationship aspects on a value-based care world, it's actually really interesting, how correlated a lot of those things are, right? Because there's still an underlying, billing documentation process, and then sort of an overlay of a value-based reimbursement, whether it's upside or downside risk. And so it still all kind of rolls back to me in many cases to the relationship between the provider and the health plan in terms of how effectively are they managing, that reimbursement in now a multi-pronged way, right? So I think the CFO toolkit of the future is going to need to have, those insights that all kind of tie together and show, the various tranches or, of reimbursement and what potential, both operational, clinical, and, financial implications and leading indicators there are that roll up to that.
Yeah, it's very, very true. If you think about it, revenue cycle 6-7 years ago was very rote, right? Before value-based care, before any incentive payments, you put that claim in, you mark the right boxes, you put the right codes, you put the right, DRG, admission, discharge, CPT, whatever it was pretty rote, and went through a system, and you got paid. Right now, we've got this little add-on, right? Value-based care, where it's a opportunity to increase your reimbursement or decrease your reimbursement, depending upon what it is that you agree that you're going to measure. And it's all about the measurement. And to the point with the CFO, they have to be involved, because they're the one who's really the person who's dealing with the payer, or they're the ones that have the quarterly meeting with Blue Cross Blue Shield or Aetna or whomever, Humana. And they have to be as involved in that value-based contract decision as the rest of the C-suite, even more, because they're the face, to your point.
Yeah,
Absolutely.
I agree. And I worked with it was a Blue Cross system out east working on, we had a value-based commercial contract, and I worked with them for 6 months to a year on their claims data, trying to clean it up, because they just put it in big buckets because it's just about money in, money out to them. But when you're sitting there looking at value-based care, what's in a cardiology bucket, what's in a primary care bucket, what's in the ED bucket, and you start separating those out, it doesn't match up as well as you'd like it to clinically. You start to run into a lot of things, and they actually were going to get a whole new system for the way they filed claims, because they were figuring out how archaic theirs was. So if the insurance company hasn't updated the way they've done claims data and tried to really get down to the basics, you got things in buckets that don't make sense, and you have to pull it, they'll say that bucket's $1 million, and then you say, well, let's pull what's in there, and you start looking, and you'd see $1,000, $10,000 things that didn't belong in that bucket. You're like, well, we're not sure how it got there, but in the end, it doesn't matter. So if a CFO has a lot of clinical background, they might be able to do it alone, but they're likely should have somebody else at their side that understands the clinical piece, that can ask the right questions, because the insurance company is going to come with their bill of goods. Hey, what about this? This looks good. And so it's very complicated.
It's multidimensional. It's multidimensional. And I mean, that's the whole point, right? It's not just the revenue cycle and specific data that you check off the boxes or put the right codes in. It now becomes that clinical data that has to intersect with that claims data. And I don't know of a lot of places that do that really, really well.
And I think that there's a lot of, technologists, and I have this battle scar from early on, and, coming into the healthcare industry, that, it's a surprise at times that those, code value sets and groups don't just kind of like come out of the source system where you can use them, right? I mean, there's a whole lot of work to do to define, like you mentioned it, right? Like, what is a cardiology patient? What is an asthma patient? I mean, that could be dozens and dozens of CPT codes or ICD codes that roll up to that definition. And so, being able to really create those groups that not only create trusted analytics and metrics, but also making sure that both organizations are playing off the same sheet of music is a very difficult thing to do in the real world of healthcare data.
And then as an aside, you throw in, everybody that graduates med school, they tell you 50% of what you learn isn't going to be true in the future. We just can't tell you which 50%. So that part's changing all the time too. What are indications for cath, for unstable angina and stents, and all of that stuff is constantly changing as well. So you might develop a system this year that now 5 years from now is way off.
Yeah, and when you think about the future, what innovations or technologies are you both seeing that you kind of think hold, that you're most excited about, right? Call it over the next couple years, that you think have the most promise and are exciting to you?
Ooh, I'll let JJ go first on that one.
Geez, I'll tell you, a few years ago, we worked closely with an IT guy in Wyoming who was really into blockchain. And for a long time, I was on, that's our future. Blockchain's going to fix everything. I'm not so sure anymore. It'll be interesting to see. I mentioned AI earlier. I think AI with reading radiology and pathology that those are very exciting because, I'm making up numbers, but a radiologist might read 1,000 CAT scans in their life, whereas a computer can read, every CAT scan's ever been done and compare it to what's out there and give you a better diagnosis. So those are very exciting to me because radiology, there's been studies showing them they can show radiologists 250 mammograms and they'll read them and then they'll shuffle them and give them back to the radiologist, and there's only a 50% concordance with themselves. So
Yeah.
I'm excited about AI when it comes to those things.
Yeah. Mine's a little different, not from the technology perspective, but I think as we look at what is happening in the merger of hospital systems and the ability for someone like General Catalyst to go in and buy Summa in Akron, and what they have an opportunity to do in terms of future healthcare. They are self-contained, self-funded. It will be a very fascinating project, I think. And likewise, the Geisinger and Kaiser merger. So for me, it's looking at the positioning that's happening, in healthcare today and what that will mean for healthcare tomorrow. I think it's going to mean changing the way we see inpatient and outpatient care delivered. I think it's going to be an increase in telehealth, which is, for me, we're really slow in that area. I believe telehealth should be just taking off left and right. And I'm not quite sure why we're hesitant in so many cases. I think part of it's just physicians want to see that patient, I hate to say this, in their office and bill for it. And it becomes a different payer contract, or perspective. But so I think when you look at the Summas and the General Catalyst and all of that, I think that becomes, a real opportunity for the future.
Absolutely. That M&A landscape, that's a really interesting comment, because I think, on this series, we're looking to really create that multidimensional view. So I think we absolutely should have, someone either from one of those organizations or a representative, private equity group that can talk to some of, how they see the industry changing. And obviously for, as a health tech entrepreneur and technologist, it has a big impact on, how organizations purchase and where they purchase and what they, what tools and things are available to them. So certainly a really, really interesting point there.
Yeah. Well, the new person in charge at General Catalyst used to be the CEO at Intermountain. And so I think he's got a great understanding and some insight into what he may want to do with the Summa relationship. And I think it'll be fascinating to watch.
Absolutely. When you think about kind of, the value-based care and risk-based contracts in general, where do you see the greatest kind of near-term potential for those transitions? I mean, there's a lot of discussions about, moving more into kind of specialties. How is Medicare Advantage going to play out? What are your thoughts there in terms of, what you see happening in the next few years with some of these contract cycles and things like that?
Well, I'm not sure. I think there's still a shuffling of the deck that's going to occur. There was quite a bit of momentum prior to COVID, and things slowed down, and now people are looking at it again. It might be anathema, but I think a single payer system is how we get to a real ACO and value-based care, because when people are jumping from one system to another, or even a Medicare ACO that's only 3 years, that's not enough time to affect health. Back to the car warranty thing, you're picking up, unless you have 100,000 or 200,000 people, you got anything less than that, you don't know what you're getting in that first 3 years. Are they taking care of themselves? Are they doing what they're supposed to? And Medicare is that sinusoidal curve, so it's hard to hit. So I think a lot of people are gun shy and with the data and things. So I feel like they're going to shuffle the deck for the next few years and then maybe come out with something else. But until we get to a single payer system, which might be 10, 20, 50 years, who knows, I think we're going to have a hard time really getting our arms around it. Yeah,
I would agree. I think they're just searching their way around right now. I don't think there's any um, Medicare Advantage or ACO program or really value-based system that has the answer. I think everybody's looking for the answer. I would think that Kaiser might be probably the furthest along,
Closest. Yeah.
but but look at, they have their own health plan and they have their own hospitals. It is self-contained, and you don't find that a lot. I think you'll see it as Kaiser moves into Geisinger, and I think they'll move down the East Coast. And I think you'll begin to see something, as I said, with General Catalyst and Summa. But I think everyone else is just trying to figure it out because they just, to JJ's point, they just don't have enough history. It's still too new, too young. And as the Medicare population grows, I also don't think that the Medicare population understands the Medicare Advantage programs. So they're hard, they're complicated to understand. And so even the education that the Advantage programs provide are still confusing to a lot of people who are covered by Medicare. So I think we're looking at just people trying to figure it out unless they've had a history like the Kaisers or even the Geisingers with their own health plans.
Absolutely. And, kind of shifting gears here, we're hearing a lot about staffing shortages and the impact it's having across the industry. How are you both seeing healthcare providers respond to this?
Well, sorry, Michelle, but the
No, go ahead.
From the physician side, I don't think that's changed much as far as recruiting physicians. I think it's been fairly stagnant or stable for about 10 years now. But where you're seeing it is in the nursing side, and what you hear from physicians is disdain for their system or their executive team of, you can't open this floor because you fired all of the travel nurses, but you can't get enough nurses to fill it. So therefore it's empty and it backs up into the ED and backs up everywhere, so they're like, why can't you pay the people? Why can't you keep the people? Because a lot of times you get a real good nurse, but now they've been there 10 years and, maybe they're making more money. And it just, to them, the physicians, it seems like you're replacing the good nurses with the younger nurses because you can pay them less, and you get rid of the travel nurses and you close floors, and everybody's trying to get things done. So
I think the labor cost has just been, so exorbitant that systems are pulling back, canceling all the travelers' continual contracts. And so you're left in situations where you do have to close floors, and you do have to reduce some of the opportunities to provide care in a different setting. But some hospitals are actually using virtual nurses to cover certain aspects of the floor, so that they are the person that might go in virtually to do a discharge, or they might be the person who goes in virtually to do the admission, in order to try to save some time for the nurses that are actually physically on the floor. I haven't seen a lot of data on how that's working. I've seen a couple systems who are expanding on that idea of virtual nursing. But, it's that is still a problem. So are therapists, physical therapists, occupational therapists, very, very hard to find. And when you look at even increasing class sizes for things like nursing school or physical therapy school, those schools cannot find instructors to be able to even increase the class size. So you're at a pivotal point where we've got to figure out a different model. And where California has a mandated nurse to patient ratio, I think that has imposed, again, reduction of floors that are open, beds that are open, and facilities that are going to continue to struggle. You've seen a large number of rural health facilities close. A lot of them in actually Texas, if I remember correctly, has probably the largest number rural critical care, critical access facilities that are closing because they just can't find the staff.
That's interesting. Is particularly the virtual nurse concept. I think there's probably a lot of potential innovation there to kind of streamline processes
Yeah.
as much as possible for the on-site staff, right?
Mm-hmm. Mm-hmm. Exactly.
What have we not covered that you think would be interesting for the episode today?
Well, if you wouldn't mind, there's one thing I'd like to tie back together, the telehealth piece and back to the
Please, yeah.
recruiting.
Sure.
Primary care has not gotten a raise in 10, 15 years. And the industry's answer to that, instead of giving them a raise, is have nurse practitioners and PAs because you can pay them less. So the doctors aren't getting, there's less and less doctors. They're not taking care of things. But, on the telehealth piece is interesting. And Michele knows some lawyers. But if you had a meeting with a lawyer that was like this, and you're discussing your case for 10 minutes, you're getting the fee for what you discussed that case. But there's, like Atlas Shrugged, there's a brain drain for physicians, especially primary care, meaning, well, I'm not going to pay 10 minutes to tell me it's just a sinus infection, or I don't want to pay $100 for that, but you'll pay your accountant $100 for 15 minutes, or a lawyer. It's quite interesting how we've really dumb that down. And I think that's why telehealth, they want to give you $20 for a visit. And a physician, if you come to my office, I get $100 or $200. Of course, I'm going to want you to come to my office. Is there added value there? Most of the time, not really.
Right.
But that's what we've done. We think, well, no, we shouldn't have to pay the doctor. And you know how it is. You got friends and you want them to diagnose you for free. But if they're a lawyer, they're not going to, they'll say, well, come to my office. I'll give you some advice at my office. So I think that's just a little plug for poor primary care out there.
Yeah.
But true. But part of it, JJ, is they haven't changed the payment methodology for telehealth. I think if they would change the payment methodology and make it a little bit more clear, I think we would see physicians who would want to use telehealth.
Absolutely.
Yeah, no question about it. Where I saw some really effective telehealth used was in school systems, right? So in Texas, where we had many different telehealth modules in the school systems in Dallas. That really wasn't the physician piece. It was really a nurse practitioner piece, to your point. But still, it really gave improved healthcare and opportunity to be given to those children in some underprivileged areas. But I go back to the reimbursement. I think that's part of the issue.
Yes, because the resolution on the camera, I can see, and if the stethoscopes you could put, if somebody's in the room, a tech that you're paying whatever $20 an hour puts the stethoscope on, show me their leg, show me the rash. You can look in their ear. There's so much you could do, especially in rural situations, which would really unburden the system and stop unnecessary, in some of these states, helicopter rides. Because they'll go to urgent care. We get them all the time, and we kind of make a joke because they say, oh, a STEMI, acute MI is coming in from urgent care, and we all look at the EKG and go, yeah, that's normal. Not sure why they were shipped over and it was a priority one. So I know in the rural states that happens. When they call a helicopter, this guy's having an MI, and you ship them to the big center. They get there and they're like, not sure why they sent you. That's a lot of money.
Absolutely. And what's different about the school setting, Michele, versus like, say, a clinic or a practice that allowed sort of that, more effective use of telehealth in your opinion?
I think when the children present to the school nurse, there was an ability to connect to a nurse practitioner if the parents had given permission for the child to be seen by through a telehealth visit. And so that child came to the clinic in the school. They were seen again if the parents approved and signed off on it, and treated, and didn't have to wait for either later in the day or the next day to have care. So they didn't miss a day of school usually. The parent could pick that prescription up on the way home if they needed an antibiotic, and the care was rendered in a much faster manner, and actually I think more effectively, especially for underprivileged areas, underserved areas.
And you couldn't
Absolutely.
afford
Yeah.
you couldn't afford to have a practitioner there all day. There might be 1,000
You could
students there,
not.
but that would be like 5 visits. If I had
Correct.
a telehealth center, I could take care of 5, 6, 7, 10 schools, and it still only be
Yeah.
20 visits. And it's one
Yeah.
person, and obviously the convenience and plus in a rural poor area, they're not even going to. You're going to tell them they need to go see a doctor. They're probably not even going to go, right? And then the
They're
kid might
probably
end
not
up
going to
getting
go.
scarlet
Yeah.
fever or something else because they didn't get treated.
Yeah. And again, you can see the ear on telehealth. You can see the throat on telehealth. You can look in the eyes. It's so well organized through a telehealth visit and really reduces the time to care
Well, it's
and get
interesting.
care.
It's interesting to think about a school or a community service like that being a hub for not only education but other needs, right, of the community, and healthcare and other things
Yeah.
that obviously there's some obligation to provide, but being having such efficiencies for the whole ecosystem stemming from that service is interesting. Something maybe
Yeah.
to think more about for especially for underserved communities could be really interesting.
Yeah. One of the most effective things I think we did in Dallas, one of the most effective.
Don't forget about the teacher shortage, right? You can't find substitute teachers. So if you could treat the teacher, they can go right back and say, oh, no, you can go back to the classroom. You're fine. That would be huge
Right.
as well.
Oh, true. Yeah. Mm-hmm.
Yeah, that's very interesting. Really interesting thought. As we look to obviously foster kind of a collective mind share here, before we close, I wanted to ask, what are some of the top sources of intelligence or information that you both draw from, just to kind of educate yourselves, or just that you could share that might be interesting to our audience?
Well, I like Becker's, and Becker's does a lot of online and webinars that I think are very good. I like the health innovation that it comes across on an email. Conferences, always conferences, whether it's, depending upon the subject that you're interested in. I think that conferences provide not only a lot of good and new information, but they provide an opportunity to network. And maybe that's the best that you can really do, is through the network that you build and the people that reaching out to hear what's happening and what they're doing. So I also rely a lot on some of the consultants, that we've used over the years, whether it's the Chartist Group or Bain or some of the more strategic groups that I've used through the years to go back and reconnect.
Well, it's interesting for me. I agree with all those sources, HBR and some other ones, but the last couple of years practicing again, I'm mostly reading medical journals, JAMA and ACP and New England Journal of Medicine. But there's so much now of this type that gets in there, either in editorials or, opinion pieces that people are working on. So it's quite interesting for me to see it from that standpoint, because certainly the academicians are looking and wrestling with a lot of these things. And when you read their analysis, they've brought some of those pieces together. So it's some very good information in there.
There's a lot of great pieces in JAMA and other networks like that on AI, machine learning, right? Some of those latest things, we leverage that quite often at Wellstack and in other companies that I've been involved with, to kind of think about how the algorithms are working, right? Just to get insight onto what data sets are available to drive value. So yeah, very, very interesting sources. Well, this has been fantastic. Excuse me. I wanted to thank both of you for the time today, and really excited to share this episode. And again, just thanks again for your time.
It's been fun.
Thank you.
Thanks,
Great.
Rich. Thanks,
Awesome.
JJ. Good to see you.